Good afternoon, everybody, and welcome to what seems to be a cooler day than we've experienced recently, and welcome to our second Meet the Finalists webinar. I'm Will Chamberlain-Webber, Joint Managing Director of Chamberlain Dunn, the creators and organisers of the Advancing Healthcare Awards for Allied Health Professionals, Healthcare Scientists, and those who work alongside them. For the past 15 years, these UK-wide awards have highlighted the often overlooked contribution that these health professionals make to prevention, diagnosis, treatment, recovery, and rehabilitation. We should, of course, by now have celebrated with our 2020 winners, but this has been postponed until the 16th of October and turned, like many others, into a virtual ceremony. So please join us then to celebrate our winners and their achievements. It will be a different experience, but nonetheless exciting, great fun, and of course everyone is invited to join in. And it certainly seems an age since the judging day back in February. How little did we know then? The gap has given us time to focus on our finalists and to invite them to tell us about their work, to reflect on their experiences during COVID-19, and to share with us how their world now looks. Before we get going, I would also like to mention a spin-off publication from the 2020 awards called Making Health and Social Care Greener, a collection of green ideas submitted by many of our entrants in response to DEFRA's Year of Green Action. It also reveals the winners of the award. You can download it from our website free of charge, www.chamberlaindunn.co.uk. Today we'll be hearing from the finalists in the Scottish Government's Award for Improving Quality, Measuring and Demonstrating Impact. This category celebrates AHPs working anywhere in the UK who have transformed the service or services, and in doing so can demonstrate an improved patient and staff experience. We are delighted that Carolyn Mcdonald, Chief Allied Health Professions Officer Scotland, is our chair today and will introduce our speakers and lead the discussion. Over to you, Carolyn.
Thanks very much, Will. So I came into post on the 6th of January, and this was my first time involved in the awards. I was absolutely overwhelmed with the number of applicants to the Scottish Government category for improving quality, measuring and demonstrating impact. And it was a real challenge to shortlist, and delighted that our finalists are here today on the call. Loved hearing from you all back in February, and really looking forward to hearing your projects again. I think AHP services never stand still, and they're always reviewing their services in terms of making sure that we're doing the best what we can for our patients. And I think we've seen massive innovation and transformation of services during COVID. And again, going back onto the website, looking at the Esteem Awards, really fantastic stuff that's going on. But today we've got three fabulous finalists to the Scottish Government Award for Improving Quality, Measuring and Demonstrating Impact. And I'd like to kick off by introducing you to Nicholas Barlow, Consultant Radiographer from the Rotherham NHS Foundation Trust. And the project title is Advanced and Consultant AHP Service Redesign in the Clinical Imaging Department at Rotherham NHS Trust. So Nicholas, without further ado, I'm going to pass over to you to tell us a little bit about the work you've been doing there. Thanks very much.
Thank you so much, Carolyn. Absolute pleasure to talk to you all today about what we're doing at Rotherham. And this change started back in 2016. So at Rotherham, we're having very much the same challenges in the imaging department as most imaging departments have had, and some continue to have, and that we have a picture of ever increasing workloads and demands on the services. We have a national shortage of radiologists, and we had at Rotherham quite ambitious report turnaround time. So the expected turnaround time for GP patients, for instance, was 3 days. At the time, the average turnaround was around 10 days. So we were well outside that turnaround time target. And also in the background, there was quite a bit of external resistance towards radiographer reporting from radiologists, and understandable in places where we'd never had radiographers reporting, because it's the unknown. What we wanted to do at Rotherham is to try and change that mindset. Wanted to look back at some of the research that had been done. So there'd been a lot of research from 2005 to present day that's shown radiographers can report examinations to the same standard as consultant radiologists. So we wanted to involve all the key stakeholders, so board directors, radiologists, CCG, wanted to involve everybody in these discussions about how we're going to take the service forwards. And we wanted to utilise a 4-tier structure. So we wanted to create a consultant radiographer-led service and a clear pathway for staff development. We wanted to increase the scope of practice of the current reporting radiographers that we had. We only had a few, and the scope was very limited to A&E, musculoskeletal reporting. So we wanted to change that, and we wanted to move the service forwards. And our ambition was really to create best practice, so to deliver the most effective plain film reporting service in the UK. And we felt that by having consultant radiographers leading the service, we could develop the current reporting radiographers that we had to give them more accountability, responsibility, to give them more satisfaction in the role and freedom to be able to express themselves and develop, push their own boundaries safely. But we wanted to create a service that delivered everything, delivered all the turnaround time targets effectively whilst providing value for money. So what we did, we had the first consultant radiographer join in 2017. They increased the scope of practice of the reporting radiographers, so they did extra training with those reporting radiographers, looking at certain diseases that you find in outpatients, for instance, inpatients. They increased the number of reporting sessions threefold. So we're getting, at the time, reporting sessions were quite ad hoc, as we established a robust reporting rota. So they had dedicated reporting sessions throughout the week, and that enabled us to be a lot more productive. So the result of that, basically, I said, you know, GP waiting times were around 10 days for a report. Within a year, that had dropped to half a day. So a massive difference in terms of turnaround time, and that will have had an impact on the patient treatment, getting the patient sorted a lot quicker on the right treatment pathway. It also has opened the door to expansion into new services. So now we've got more radiographers trained up in other areas. We can look at branching into hot reporting, radiographer-led discharge, which we're going to be doing by the end of this year. We're also now immediately reporting NG tube examinations. So to have an NG tube in the wrong position and feeding the patient is a never event. It should never happen. And now, because we're reporting these examinations immediately, we're flagging this up to the clinicians immediately. So in theory now that should never happen. So that's brilliant. We can also look into newer services. So a rapid lung cancer pathway, for instance, where patients would come from the GP. If we found something suspicious for a lung cancer, we would report that straight away, and we can get them into CT for further imaging either on the same day or the following day. So again, that's really shortening that diagnostic time. And with the new faster diagnostic standard, that patients who are referred for investigation of a suspected lung cancer should find out within 28 days whether they've got a cancer or not. Services like that are pivotal to making sure that those patients get through in that time and get diagnosed early. So it's opened doors to new service expansions, which we're hoping to do in the coming year or so. One thing that we really wanted to do, though, is demonstrate the safety aspect of the service, because one of the big challenges that we've had, and one of the big concerns from radiologists in particular, is quality of reports. So what we did, we significantly increased the number of studies that we peer review as a team. So in 2016, over the year, that was 400. It's now over 4,000. So the minimum expected audit by the Royal College of Radiologists is around 5% of annual workload. So we're on about 7%. So we're well above that expected minimum audit level. And the current average accuracy of the reporting team is 99.3%. So the minimum is 95. So again, we're showing that we're well over that minimum level of accuracy. And that's the sort of accuracy that we're achieving every quarter. We look at this monthly, and then I compile quarterly reports, and we're constantly achieving over 99% accuracy. So really encouraging, and we can use that evidence then to further solidify our position and reassure the radiologists. What we have seen is a significant increase in the number of reports done by radiographers as opposed to medical colleagues. So before we implemented this new service, we were reporting around 44%. Now we're reporting just under 83%. So again, a huge increase. It was the highest in the country. I believe we've been overtaken recently by another trust, so we'll have to sort that out next year by increasing our scope further, but still significant improvement, and it's allowed the medical colleagues to focus on more complex cross-sectional examinations. The waiting list for these to be reported are high, and you know, all radiologist colleagues have said how grateful they are that we've taken that workload off them. You know, they're safe in the knowledge that we're doing this service effectively. They can leave us to concentrate on those plain films, and it allows them to deal with all the CTs, MR, nuclear med, etc., that would otherwise be waiting weeks to be reported. So they're really grateful for this service. And of course, we're working closely with them all the time. We've got to move away from looking at it as, you know, reporting radiographer team, radiologist team, general radiographers. We've got to look at it as one team working together, and we're in constant communication with the radiologists, particularly during COVID, as to, you know, looking at BSTI guidelines on reporting, etc. How can we deliver the most effective reports in COVID? So staff morale has increased with the service as well. The reporting radiographers, because of a lot more scope, a lot more freedom to express themselves and develop their own practice, to work autonomously, to make their own decisions, but also for the radiographers on the shop floor. So I mentioned about the 4-tier structure. This is what the 4-tier structure is all about. So in theory, you could have anybody from, you know, an assistant practitioner progressing right up to consultant radiographer. If that post, if myself or my colleague Rob left, you know, the scope for somebody to move up, so that there's a clear pathway there for development. And the, you know, the radiographers that are into plain film reporting, they really appreciate that pathway, and it's keeping them at Rotherham. Before all this, we struggled to hold on to staff. We lost a lot of staff, and we struggled to recruit them, and now we're fully staffed because they're seeing the potential for improvement. Because there's consultant radiographers there, we can also help with things like research. So we help other departments with the research. We've helped people in CT, MR complete their MSCs. Everybody in the reporting team will hopefully progress to do an MSc. So everybody within our team will be working to advanced practitioner level with those skills to contribute to research. And a lot of the general radiographers, we're helping them with audit and research as well. So they're coming to us for advice. We're helping them to publish research, and they're sharing it within the department. They're promoting it, showing off what they're doing. The best thing about this, I think, is the sustainability and the transferability of it as well. You know, it's not a mind-blowing thing that we've done. It's not a really difficult thing to implement as long as everybody buys into it. So once you've changed that initial mindset of the safety element, once you start getting more reporting radiographers in, expanding the team, expanding the scope, you start reaping the benefits. We're planning to expand the consultant-led practice into other areas. So we've just recruited a breast consultant. We're also looking to do it in MR, CT, ultrasound. The national profile of the trust has increased. People are talking about Rotherham and what we're doing, and we've had multiple people from other trusts approach us for ideas as to how they can improve their services, which is absolutely great. And we're ourselves looking to expand the team as well. We've got another trainee reporter in MSK, and we're looking to bring in another trainee next year. So hopefully we can progress towards 7-day reporting as well. Now in COVID, like everybody, our reporting services again had to adapt to the new ways of working and the number of patients that are coming through and the new demands. So the clinicians wanted rapid diagnosis of the COVID patients so they could get the treatment sorted quickly. So what we did as a team, we changed our working pattern. So myself and my other consultant colleague Rob reported on weekends from home, so we could deliver a temporary 7-day reporting service. At the time, you know, there's only 4 people in this team, but we managed nonetheless to produce a 7-day reporting service for those patients. In a lot of places, the radiologists have taken back control of the chest reporting in COVID. Some people have told me that's due to a lack of trust in the reporting radiographers. Others have said because of the interest of it, the radiologists wanted to do it. But for whatever reason, those reporting radiographers have had that taken away, which I think is a shame. Whereas at Rotherham, the radiologists, thankfully, have been really supportive. They've seen, you know, we report pretty much all the plain films that come through. So they said, well, who better to report these COVID plain films than the radiographers? So they've allowed us to continue reporting them. And the turnaround times have stayed exactly the same than what they were pre-COVID. So an average of 0.7 day turnaround across all referral sources. So really proud of how the team has adapted in COVID, of how we've worked together with the radiologists. The protocols for reporting have been changing constantly as new guidance has come out, as more research has been done. And we've worked together to make sure we've kept on top of those, and we've produced effective, clear reports for the clinicians, and we've had very good feedback from the clinicians about the radiographer reports that have been produced and how it's helped them to diagnose these patients correctly. So that's everything really about the service where we're at the moment. I'm happy to take questions. I know it's only brief, but I don't want to keep you all forever. So has anybody got any questions at all about what we're doing, where we're going, how we've adapted in COVID?
Thanks very much, Nicholas. I've really enjoyed listening to your presentation a second time. I think what you've done in Rotherham is really fantastic and absolutely meets solidly the criteria for the Scottish Government Award for Improving Quality, Measuring and Demonstrating Impact in terms of the sustainability and the innovation and long-term improvements. So thank you for that. What I would do is I would ask our participants if you could think of some questions for Nicholas. I'm going to move on to our next presentation, and we'll come back to the questions at the end if that's all right. So if you could put your questions in the chat box, that would be great, and Nicholas can see them as we're moving on to our next presentation from Andy and from Gemma in NHS Ayrshire and Arran. And this project title is around transforming the management of Cauda Equina syndrome in Crosshouse Hospital. And it's a joint work that's gone on around with the advanced physiotherapy practitioner, I beg your pardon, within Crosshouse in the emergency department. And this was in relation to people with back pain coming in and reducing their hospital admissions. So Gemma, I'm going to hand over to you. Thanks very much to yourself and Andy. Thank you.
Hi there, thank you for inviting us to the webinar for the Advancing Healthcare Awards. My name is Gemma Taylor. I'm an advanced physiotherapy practitioner at Crosshouse Hospital.
And I'm Andy Tanagho. I'm a consultant orthopaedic surgeon in Crosshouse Hospital.
Mr. Tanagho very kindly nominated me for this award and has also supported me in the transformation of the management of Cauda Equina syndrome in Crosshouse Hospital. Cauda Equina syndrome is a neurosurgical emergency resulting from spinal cord compression. This can lead to long-term bladder and bowel dysfunction and also limb paralysis. If not managed urgently, this can have considerable litigation consequences and also has a significant impact on a patient's life. Before 2016, patients that attended the emergency department with back pain were admitted to Crosshouse Hospital, often for an MRI scan to exclude Cauda Equina syndrome. Such patients experience lengthy waits in the emergency department awaiting orthopaedic assessment. Duplication of assessment was not uncommon, and the assessment were usually performed by a junior medic who then required senior support to make final decisions. In 2016, the Scottish Government provided 9 months of non-recurring funding to test an advanced physiotherapy practitioner in the emergency department and trauma and orthopaedics. With the success of this, in 2018 the role was made substantive. The main driver was originally to improve back pain management and reduce hospital admission. The role has been and continues to be highly supported by all departments, including the emergency department, orthopaedics, radiology and neurosurgery. The measurable outcomes include a 3-year 50% reduction in hospital admission. This is despite a 25% rise in back pain attendances. The 4-hour target to treat is improved from 87% to 96%, and this has been maintained throughout. The establishment of the new Cauda Equina protocol has enabled faster access to same-day or outpatient MRI scan. The reporting of such scans has also been expedited. The annual estimated savings are between 31,560 and 37,800, calculating a reduction in the length of hospital stay. As you can see from this chart, the in-hours admission in 2015 was considerable. Once my role was established and training was complete, the admissions started to fall. There were some spikes in the graph, which represents when I was in leave, and then there's further significant improvements with the introduction of the new radiology protocol. Again, the 4-hour target to treat has significantly improved from 2015. Again, there might be some slight dips in this graph, but that usually reflects patients that have to wait to be transferred to neurosurgery, but they are waiting in the emergency department rather than in a hospital bed. This is the new Cauda Equina radiology protocol. Patients who present with a rapid onset of symptoms and have a progression of these symptoms receive an MRI in the same day, usually within a 4-hour window. The average wait for the MRI is 2 hours. Patients who present with more stable symptoms that have been there longer than 4 weeks would go on to the outpatient Cauda Equina protocol, which endeavours to scan these patients within 72 hours. The average wait is 24 hours. The reporting is the following day as opposed to an average wait of 2 weeks for reporting, which is indeed far more safe for patients. I would actually note when the patient's getting an outpatient MRI scan, and I actually check the scan once it's been completed. So we're usually already checking the MRIs before they're reported. So despite a 25% in back pain attendances, we've achieved and maintained a 4-hour target to treat above 96%. Reducing hospital admissions has also been sustained. This is cost effective, but ultimately it improves patient care. Patients have a single point of contact for patient care. I conduct the assessment, arrange the MRI, review the MRI, discuss with senior orthopaedic consultant or with neurosurgeons. I provide patients with feedback and I arrange subsequent follow-up. I think having a single point of contact is so important for patients. I can also commence physiotherapy and arrange follow-up physiotherapy where appropriate. It's myself that phones the neurosurgical team and arranges the transfer from ED up to neurosurgery when required. For staff, this has had significant reduction in pressure on both ED and trauma and orthopaedic medics. There's also a sharing of the knowledge of back pain management, and this ultimately improves patient care. There has been no complaints or no medical legal action yet. Fingers crossed. This is just some feedback from patients that have been under the care of myself who have attended with suspected Cauda Equina. I would like you to draw your attention to timely, informative and consistent, not always words associated with unscheduled care. I'd also like to highlight that patients feel cared for when there is a single point of contact and they feel reassured that somebody is looking after them on an ongoing basis in this rather unsettling time. I would draw your attention to the Gemma has a lovely compassionate manner. I personally have had COVID and have been working in the challenging conditions that COVID has brought to us, and I have to say that I would like patients' feedback now to see if I'm quite as lovely and quite as compassionate. Am I? So this isn't about me. I have helped to lead the change, but I know that the change would not have been implemented without good teamwork. I have appreciation of other departments and their capacity and the pressures. I acknowledge my own scope of practice and seek help where required. I respect colleagues, but in return gain respect. I believe that you need realistic goals and expectations when managing this complex patient group. But equally, patient safety is paramount, and we must not forget that. This team approach ensures sustainability and is required for ongoing service development. The new pathway is accepted now as standard daily practice. There are no variations despite increasing hospital pressures and staff turnover, and even within the circumstances of COVID-19, we have managed to maintain these results. The audit shows sustainability in hours, but it does show significant out of hours data. This is the 4-hour target to treat breaches, and it shows very inconsistency with these breaches, and they're falling below the ideal target. Again, the out of hours admissions are sitting and probably staying stable at 11%. This model of care is transferable to other trauma units and major trauma centres, but key stakeholder engagement is required. The key requirements, in my opinion, would be a suitable trained APP to drive forward change, monitor it, audit it, and implement it on an ongoing basis. With this, you need multi-departmental support and obviously funding to implement and to ensure future sustainability. In summary, I think we can acknowledge that Cauda Equina syndrome is challenging and time-consuming to manage. To my knowledge, I'm the first APP within Scotland to really transform the back pain management in the emergency department and trauma and orthopaedics. The success of this role has been evident, but further improvements could be made in out-of-hours care with more resource and funding. Thank you. That's over to you.
From my perspective, there are 2 points to highlight. From the orthopedic department perspective, Gemma's work has been remarkable in bringing 4 departments: emergency department, the orthopedic department, radiology, and the neurosurgeons together to agree to a pathway for a group of patients that are challenging to diagnose and manage. My second and last point was the impact of this pathway was noticeable during the COVID pandemic, because all departments tried to change practice to try and reduce unnecessary hospital attendances and admission. And again, this work proved that it was very useful during this time. Thank you for listening.
Thanks very much, Gemma and Andy. As I said with Nicholas's presentation, I've thoroughly enjoyed hearing the presentation again, and absolutely robustly met the criteria for the Scottish Government Award for improving quality, measuring and demonstrating impact. I'm delighted to see, Gemma, that you're looking as well as you did in February, despite the fact that you've had COVID. Terribly sorry to hear that. And glad that you're back at work and doing the excellent work that you're doing. So again, with the participants on the call, if you could record your questions down the chat, we'll come back to those at the end. We'll do all the presentations first, and then we'll hear your questions at the end. So our last finalists are Chris Maclean and Fiona Nolan in the Golden Jubilee National Hospital on the west coast of Scotland, and their project title is Mobilisation of Patients on Femoral Intra-Aortic Balloon Pump. So over to Fiona and Chris, thanks.
Thank you, Caroline. just like to thank everybody for the opportunity to update you on our new service of mobilising patients on femoral intra-aortic balloon pump. This was very much a team effort, and the other leads unfortunately can't be here. Natalie Lambie and Ross Marsheider were very proactive in helping establish this new service at the Jubilee. The Golden Jubilee is the Scottish National Centre for Advanced Heart Failure, and we're the only centre in Scotland who carry out heart transplants. And some of our very urgent patients require augmentation on an intra-aortic balloon pump, which is a catheter inserted through the femoral artery into the aorta. Now, historically, when these patients, when they require this, they have to stay in hospital, and historically we're on bed rest, and this can be for many months. We've had a patient on bed rest for 10 months, which was probably the patient that really prompted us to get this new service going. Physio involvement for these patients was very limited. It was very much a maintenance exercise programme. We did some deep breathing exercises. We used the bed bike, but with prolonged bed rest, as all physios know, there is a loss of muscle mass, a decreased functional ability, psychological issues, and a prolonged post-transplant recovery. So as physiotherapists, we wanted to offer these patients a better, a more proactive service, a service that would not only attempt to maintain their function preoperatively, but would optimise them for their heart transplant. It would enhance their long-term hospital stay and help with a positive post-transplant outcome. So, following much collaboration, many meetings, lots of rewriting of protocols between the physios, between the cardiologists, the nursing team, the surgeons, clinical governance, and the patients, the cardiothoracic physiotherapy team developed a protocol and piloted a service improvement project to get these patients mobile. This allowed them to be physically and psychologically more prepared for their transplant. Our first patient, our pilot patient, consented and walked for the first time in November 2018, and we believe that this was a UK first because, as I said, it's not normal practice for these patients to be up and walking about. This particular patient remained on the balloon pump for 134 days before his transplant, and during that time we mobilised him 105 times with no adverse incidents. And his personal best, the most he walked in one day was 4.17 kilometres in 2 sessions. That was a long walk. Our step count was through the roof, so it was really good. He was successfully transplanted in March 2019, progressed very well and very quickly. He was extubated 12 hours after his transplant, which is very, very quick. Most are 24 to 48 hours if they're making a routine recovery. He achieved all his physio goals by day 11, so he was walking independently, he was independent in his self-caring. We were introducing a progressive exercise programme for him. He had completed stairs, and from a physio perspective, he was actually ready to go home 11 days after his transplant, but he, because he was on IV antibiotics, he stayed till day 18 and then he was safely discharged home. So since 2019, this has become our standard clinical practice for patients awaiting transplant on femoral balloon pump. We've successfully mobilised and optimised 10 patients involving almost 600 sessions, and to date there have been no major adverse incidents. The team have received very positive feedback from patients and from the wider MDT. Our cardiologists and surgeons have been incredibly supportive of this, and we do thank them. They recognise it's a vital service, and we believe it is a very vital service that we're doing. During the COVID-19 pandemic, we did continue to walk and optimise these patients. However, due to the increased risk to them, we had to mobilise them within the confines of advanced heart failure, which was a 15-metre corridor that we had access to. So whilst this keeps the patients mobile and it keeps them physically fit and they get the physical benefits of exercise, because we're unable to leave the units, the patients have suggested that they don't get the same psychological benefits from the change of scenery. Fortuitously, we met one of our patients at the outpatient clinic last week, and he gave us some informal feedback and emphasised to us the importance of the service. He had been inquiring about the physio team and if we were still mobilising patients on balloon pump. He was delighted to hear that we were and reiterated how important it was for him to be mobile whilst waiting for his heart transplant, both physically and psychologically. He asked if the pandemic had restricted us in any way. We discussed with him that it had, that mobilisation was now limited to the advanced heart failure unit. He described that he had been in a similar situation. Initially, he was able to walk out with the unit, but due to some medical conditions, he then was restricted to mobilising within the unit itself. He said that he felt huge psychological impact when he was restricted to his mobilisation to the unit. Mobilising out of the unit reminded him of life beyond the advanced heart failure ward and the importance of a change of scenery, seeing different faces were massively beneficial for him. He said it was only since he had gone home and had several periods of reflection that he had come to realise just how important it was in ways he couldn't have imagined before he consented to take part in this mobilising on a balloon pump. As a team, we are committed to progressing and sharing this practice with our physio colleagues and other transplant sites. We were invited to talk at the Society of Cardiac and Thoracic Surgeons conference in Cardiff in March, but that was unfortunately cancelled due to the pandemic. But we will be attending and presenting in Belfast in 2021. We have been approached by physiotherapists from St Bartholomew's and Withamshaw asking to see our protocol. We're very keen to share this progressive innovative service, and we would like to see it rolled out for all these patients. We firmly believe that this is a vital service for transplant patients. So thank you very much for listening. I think Christina Maclean, who nominated us, who is our head of rehabilitation, is going to have a few words now. Socially distanced, of course.
Thank you. Thanks, Fiona. It was really just to kind of reiterate what Fiona said. Here at the Jubilee and within the department, we like to promote research and innovation to continually improve patient services. And I think this is a perfect example of how the rehab team, and particularly the cardiothoracic team, have taken that concept and developed it to the betterment of our patients here at the Jubilee. Our focus is always on patient-centred, safe and effective care as across, kind of NHS services. And I think this is a perfect example of how the team have achieved this. Very person-centred, and that it's focused on the patient and the outcomes of the patient, both during their stay within the hospital, but also in terms of their outcomes post-surgery. It's safe in that they followed all of the governance and the protocols. They kind of collaborated with the wider team to make sure that there was proper governance around about what they were doing. This was our first time in the UK, so it was a bit of a kind of leap of faith, but we made sure that everything was safe for the patients throughout, and also safe for staff, because it was a new innovative technique in terms of mobilising these patients that had never been done before, and we wanted to make sure that staff felt safe as well. And it has been effective, because what we've demonstrated is that it's actually reduced the length of time that patients are staying in hospital post-operatively after the heart transplant, and that's because we've managed to optimise them prior to their surgery. So great example of rehabilitation in action, and hugely proud of what the team have achieved in this time. Thank you.
Thanks very much, Chris and Fiona. And again, another finalist in our category of the Scottish Government Board for Improving Quality, Measuring and Demonstrating Impact. And I think everybody will agree absolutely robustly meets those criteria. The chat is very quiet, so I'll ask the attendees and participants on the call to enter some questions in for our finalists. I'm going to kick off with, I've got a question for all three of you actually, different questions, but I'll start backwards and work towards Nicholas. But Fiona, you talked, we launched in Scotland yesterday the Recovery and Rehabilitation Framework for patients during and after COVID. And one of the things that we featured very strongly was prehabilitation in that. But it's lovely to talk about it live today with yourselves. But one of the questions I have for you is about risk. So it struck me, and I know we've kind of asked you this question before, but it struck me that what you were doing was a really risky, pathway in terms of getting patients, because you've never done this before. It's first in the UK. What type of protocols and governance did you have to put in place, and did you have any pushback from your own physiotherapist or any other members of the MDT around the potential risk to the patients in terms of getting them up walking with the balloon pump prior to surgery? Thanks.
So we first thought about doing this about 5 years ago, and we approached Maclean, who are the actual manufacturers of the balloon pump, and they had said that no, they couldn't support it, they wouldn't be willing to do that. So there was lots of talk in the hospital about getting subclavian balloon pumps in, and there certainly is a name that the surgeons are trying to do. However, as with all these things, it takes a long time. And we had one patient, I think I mentioned earlier, who was in here for nearly a year and was bedbound for 10 months, and we worked very hard with her, but we could see that her muscles were deteriorating. We had numeric values that showed that she was losing a lot of muscle mass. So we decided to approach Maclean again, and we were very lucky. They said yes, that they, if it was a robust enough protocol, they would be happy to do so. So we did some journal searches. We knew there had been mobilisations in Norway, and we knew some parts of the States had done them. The information was scant, but it had been done. So we in this hospital do ventricular assist devices, and we had a very robust protocol for mobilising patients, because we were one of the first hospitals to mobilise patients on a ventricular assist device. So we took that protocol and we changed it, but we made it very robust. And if you'll remember from the protocol, to actually get a patient from the bed up for their first walk normally takes about 10 days. We have various stages where we do measurements throughout. For our first walk, we always have a cardiologist in the department. So essentially we spoke at great length with cardiologists, the surgeons, and they knew the ethos of what we wanted to do was the right thing to do, but it was about doing it safely. So we felt that we had negated as much as we could of the risks that were there, and we were very aware that it was the first time. So as you can imagine, the very first time we did it, we had lots of staff about, with the cardiologists there ready to help us if needed. And as I say, we have had no adverse events. We have just renewed our protocol with clinical governance, and we tweaked it for a couple of bits and pieces. So it took a while to get it through, and unfortunately the lady that really prompted us to push for this was, well, fortunately for her, she was transplanted, so she never walked. It was the patient after her who was our first patient. So we think our protocol is as robust as it can be, and when you're with people, there is always a risk, but we try to minimise that risk, and I think the protocol has proven that we have mitigated the risk as much as we could.
Great, thanks, Fiona.
If I could just add that as well, I think you did touch on it, Fiona, but the protocols were all kind of scrutinised and approved through our clinical governance, our internal clinical governance group, which had medics and clinicians, as well as our kind of clinical governance team. So it was all approved with respect to that. So it wasn't something that was done just as part of the physio department itself.
Great, Thanks very much. Thanks both. My next question, and please, you know, the chat's very quiet, so please, other colleagues, input to the chat in terms of questions for our finalists. But my second question was for Gemma and Andy, and really excellent examples of a number of departments coming together to benefit patient outcomes. And again, with regard to the rehabilitation framework that was published in Scotland yesterday, we're seeing quite a lot with COVID, the impacts of physical and mental health. And I think sometimes the NHS can be guilty of boxing patients into their specialty, so into their neurology or their orthopedics or their GI. And again, with patients who've had physical and mental health repercussions following COVID. I'm wondering if you've got any tips as to how you got your 4 departments that you spoke about together in terms of making sure that it was absolutely person-centred and outcomes focused for each individual.
I think when you come into a department, you can take a step back when you're a profession that's not usually in that department, especially within the emergency setting, and you look at how things are done for the department. Although the patient's interest is always forefront, you do see how there's breaches in the emergency department. Radiology are looking at how they can fit an MRI into a schedule. Orthopedics are looking at, well, do they really need to be admitted? When you actually take a step back and look at the patient's journey in this example, there was a lot of unnecessary things happening, and it took quite a lot of time, and you had to get a lot of senior buy-in from the clinical directors to constantly meet them at the start to say, regardless of what the pressures are in a department, if you look at that patient, solely that patient, there's a lot of things happening to them that could be prevented, and gave them case example after case example of how we could improve that. And it was a constant re-evaluation, meetings regularly, until we got radiology on board to agree a new protocol, until we got orthopedics to then support senior decision making at the front door without admitting them for a scan, think about it before admitting. But there was this constant reassurance of perhaps case examples to be able to showcase why it was in the patient's best interest, not a department's best interest, to make these changes. I hope that answers the question.
Yeah, that's really helpful. Thanks very much. Thanks, Gemma. And my final question is to you, Nicholas, and it's kind of pertinent because in Scotland we don't do chest reporting yet. We do MSK. Our radiographers do MSK, and I'm wondering also in terms of setting up the service that you did and the excellent outcomes that you have, if you've got any advice to Scotland in terms of getting that wider stakeholder group on board. So you're pushing against an open door with the radiographers here. You know, we absolutely, our radiographers really want to engage in chest reporting, but sometimes, you know, the wider stakeholder groups that we work with aren't maybe on the same page yet. So I'm just wondering, from Rotherham point of view, if you've got any tips for us in Scotland around some of the conversations that you had in terms of meeting the outcomes for patients, the journey you're on.
There's so many benefits, Carolyn, and you know, if we look at the key stakeholders in it, so board level, that they're looking at cost effectiveness, quality, patient care, and effectiveness of the service. So if you look at it in terms of cost, radiography reporting is a lot cheaper. So average cost is about £3 compared to £5. So if you think that over the course of the year we're reporting just shy of 80,000 plain films, that's a big cost saving for the department. So there's that element to it. In terms of effectiveness, I mean, there's such a shortage of radiologists. They have to do absolutely everything, all the cross-sectional, that they're absolutely snowed under. So in terms of report turnaround times, unless you're lucky enough to have a glut of radiologists, you're not going to be able to report those plain films in the required time. And a lot of places have backlogs of weeks. Now COVID has partially reset that because the patient numbers have dropped, but it's only going to get, as more patients start to come back in for routine things, this is a perfect time now to be thinking, right, it's time, we've pressed the reset button in a way. we've managed to clear most of the backlogs because we haven't had the number of patients coming through. But what about when they all start coming back? We need to be planning now for the future, long term, and think, how can we deliver this effectively so we don't get into a situation where we're having to outsource these studies all the time, or the radiologists are that stressed because they can't keep on top of work that they're leaving, and we're not getting the required number of radiologists in. So radiography reporting is an effective way to deal with that. In terms of radiologists, a big concern is the safety aspect, which I can understand. It's what their passion, and I'd be concerned if they weren't concerned in a way, because this has traditionally been their role that they've had control over. It's not about radiographers just taking that role away. Again, we've got to work together. We've got to show the safety. So, you give ours as an example by giving us the opportunity. You can't show the safety. You can't evidence safety without having the opportunity to do it first. So because they bought into it, we can now audit ourselves rigidly to the required number and prove every single month that we're meeting those standards. And we go to the quality governance meetings every month with the clinical lead radiologists, and all the discrepancies that come up, we have what's called a realm meeting, so radiology event and learning meeting, where we discuss any discrepancies, any good spots, etc. And we feed this back in, so the radiologists have input into those meetings as well. So we're working together. So I would sell it to the radiologists that if they get involved with the training, they can oversee it. The radiographers will be reporting to their style, to their standards. If they don't get involved, this will come eventually in Scotland, and only by getting involved will they be able to ensure that initial training is of sufficient quality, and then the radiographers can evidence it with the audit. So there's multiple elements to it. I think, unless people take the plunge and look at the success in other areas, because everywhere in the UK that have reporting radiographers, to my knowledge, it's been a success. I've never seen a story where they've had reporting radiographers and it not deliver and it not work and it not be safe. So I think they need to look at these examples, look at what we've done at Rotherham, give them the backing, give them the training, and that will pay off long term for radiologists. We help train all the radiology registrars that are coming through. We do their plain film training for the radiologists, because we've got to that level now where they're comfortable, they're confident in our abilities. So we're helping to train the next generation of radiologists that are coming through. So hopefully over time that mindset will be changed. Mm-hmm. But we can help each other. It's about looking at it as one team, not them and us, not two different teams, working as one team to deliver a common goal, which is getting these patients the best possible treatment. And to do that, we need to report these x-rays as efficiently and effectively as possible.
That's great, Nicholas. Thanks very much for that. I've got one more question, I think, coming in. I'm just kind of conscious of time, and that's from Joy. It's to all three of you, actually. So we'll maybe start with Gemma and Andy first. Thank you for sharing your work with us, Joy is saying. From your experiences during COVID, where you've made changes in your service, is there one particular change or way of working that you'd like to see continue? Andy and Gemma.
During the COVID peak, we've changed the way we're working by extending the working hours to be at the front door. So we've created like an assessment unit area so that we can see the patients at the front door to try and reduce admissions and waiting time even further. And this was very effective. So, but it's only for a short period, because the resource is not there to have this as a sustainable long-term plan. So probably more resource, to have this kind of work extended to out of hours or to longer working hours might be more effective. Do you think?
Yeah, and I think the model of senior support and teamwork at the front door is really important. I think if you get it right at the first time when you see that patient, you can prevent a lot of reattendances, and you can really hit it hard there and then, rather than this kind of backlog or a kind of backward approach to patient care. So I think when we did the orthopaedic assessment unit in COVID, during COVID pandemic, we really noticed a very united team approach, and it let everybody see how this system could work better rather than it probably being more reliant on myself doing it. Everybody took on that role and, you know, started expediting the patient care, trying not to admit first, rather than it being reliant more on myself being there.
Mm-hmm. Very helpful, useful. Thank you for that. Fiona and Christina?
I think for this service, really it restricted our practice because we couldn't bring the patients out of the advanced heart failure unit. So we definitely wouldn't like to keep that. We really want the patients walking as far and as much as is safe for them to do. I think because we had a reduction in our elective services, we were able to get a few more people trained for completing this protocol, because it is a very robust protocol, and we do have 2 members of the physiotherapy team, and it had historically always been senior members of the team plus a junior or a healthcare support worker. So we've been able to train some more people. But
oh, that's terrific. Yeah. Just in terms of that sustainability, that's fantastic. Great. Thanks. And finally, Nicholas?
I think the 7-day working has to be a priority. It's nice guidance to do 7-day immediate reporting for ED patients. So we certainly need to be looking at that in the future. And I think there's potential at Rotherham to do hot reporting of GPs eventually. I'm not sure how that fits in with GP waiting times, but that's something we need to discuss with the CCG. But I definitely think we need to be starting to move towards a 7-day hot reporting, so we can make sure that nothing's getting missed by clinicians.
Great, thank you. So there doesn't seem as if there's any more questions coming in, but what I would like to say is that I hope the people who are watching the recording of this in the future are as inspired as I was, and as my fellow judges were on the day that you all presented down in London. I think what you're doing is fabulous work, really inspiring, and absolutely, as I say, meet the requirements for the Scottish Government Award, but more importantly, meeting the patient outcomes of those that you're dealing with. So huge thanks to you for coming on the webinar today and for sharing your work. And I'm just going to pass you back to Will. Thanks, Will. Well, you're on mute. That's it.
Well, thank you, Carolyn, for talking us through the Scottish Government's award for improving quality, measuring and demonstrating impact, and for so expertly leading the subsequent discussion. I think you'll all agree that we've heard from 3 excellent projects, any of which could be a deserving winner. Sadly, we must still wait until the 16th of October to find out. So make sure you put the date in your diary and be prepared to celebrate your achievements. On behalf of Chamberlain Dunn and the Advancing Healthcare Awards team, I would like to thank our speakers today, Nicholas Barlow from Rotherham NHS Foundation Trust, Andy Tanagho and Gemma Taylor from NHS Ayrshire and Arran, and Christina Maclean and Fiona Nolan from the Golden Jubilee National Hospital. And to all of you, thank you for taking the time to join us, and we wish you luck for the virtual awards ceremony on the 16th of October. Registration will be open soon, and details will be found via the Advancing Healthcare Awards website and on Twitter. Thanks, of course, to Carolyn Mcdonald, Chief Allied Health Professions Officer Scotland, for her insightful chairing and generosity in sponsoring this award. This webinar is part of a series featuring many of the finalists from this year's Advancing Healthcare Awards, and the next webinar in this series will be also sponsored by the Scottish Government, will be next Thursday, the 20th of August from 12 to 1, and will feature the healthcare science finalists. Then on the 22nd of September, there will be the AHP Clinical Leadership webinar sponsored by Allied Health Solutions, and further details of this on the website. Remember, please put the 16th of October 2020 in your diary, tell all your colleagues, and look out for the registration details to be announced soon. One final thank you must go to Rachel, Joy and Ellie, our in-house team, who have worked tirelessly to make these webinars happen both organisationally and technically. And finally, this webinar will be available on our website, together with all other webinars in the series at www.ahawards.co.uk. So please share with your colleagues who weren't able to join. Thank you for tuning in and enjoy your weekend.